advisor for the India Primary Healthcare Support Initiative project of Johns Hopkins University. Dr. Shukla has had a 35-year-long career in the Indian Administrative Service as a part of the West Bengal Quadrant. During his time in the Ministry of Health and Family Welfare at the Government of India, he worked on disease prevention and control programs under the National Rural Health Commission. It was during his tenure at the National Institute of Communicable Diseases was transformed into the National Center for Disease Control. He has a master's in public health, as well as a PhD, both from the Johns Hopkins Bloomberg School of Public Health. Dr. Amita Gupta, who's also with us today, is the Deputy Director of the Johns Hopkins Center for Clinical Global Health Education, a professor of infectious diseases at the Johns Hopkins School of Medicine, and holds a joint appointment at the Johns Hopkins Bloomberg School of Public Health. Dr. Gupta specializes in international public health, clinical research, education in infectious diseases, HIV/AIDS, tuberculosis, and antimicrobial resistant infections. Since 2003, her work has focused primarily on India, where she leads several Indo-JHU research collaborations. She also serves as the leader, as a co-chair of the Faculty Steering Committee of the Johns Hopkins India Institute. Dr. Ramanand Lakshminarayanan is an economist, an epidemiologist, and the founder and director of the Center for Disease Dynamics, Economics, and Policy, or CDEP. He has also a faculty member of Princeton University, as well as a faculty appointment in the Department of International Health, also at Johns Hopkins University. He served on President Obama's Council of Advisors on Science and Technology related to antimicrobial resistance. His research on epidemiological models of infectious diseases and economic analysis of drug-resistant health gets attention from leaders and policymakers around the world. During the second wave, Dr. Lakshminarayanan launched Oxygen for India, an initiative to deliver medical oxygen to where it was needed most in the country. Last and certainly not least, among our panelists, we have M.R. Rangaswamy, who's a software executive, investor, entrepreneur, corporate eco-strategy expert, community builder, and philanthropist based in the US. In 1997, Mr. Rangaswamy co-founded Sandhill Group, an investment and consulting firm which made several notable investments, produced the Enterprise and Software Conference Series, and launched Sandhill.com, an online resource for software business strategy. In 2012, he co-founded Diaspora to unite Indian Americans and to transform their success into meaningful impact in India and on the global stage. And helping to moderate our discussion today, we are lucky enough to have Vikram Chandra, an Indian journalist who has founded Editor G Technologies, a multilingual video news platform on which we will also be streaming today's conversation. And with that, I'll turn it over to you, Vikram, to lead our conversation.
Thank you so much, Brian. And I have to say, it is such a pleasure to be doing this. We've done shows with Johns Hopkins in the past and with the India Institute, and it's, I think, really important to spread good, credible information, especially around something like COVID, and in India, where that information has not always been easy to get, especially at the height of the second wave. I'm going to try and keep this as freewheeling as possible. So please do feel free to come in to add to what anybody else has said, or to cut me off. Please feel free to do that. We are streaming this on Twitter and elsewhere, and on Editor G. So if any of you have any questions that you'd like the panelists to answer, please do fire them in, tweet them, and we will try and take those questions for you. I'm just going to kick off straight away. And by the way, just to let everyone know, Dr. Devi Shetty has had to go in for an emergency surgery right now, so he may or may not be able to join us. We'll have to see, depending on how that surgery goes. I guess saving lives is of course the most important priority for any doctor. Right. If I could just kick this off by asking all of you the question that I think everybody, certainly in India, is waiting to ask. And that is the question of whether there is going to be a third wave or not. We've had a terrible second wave. There are a certain number of cases that happened. Today, enough time has passed from the second wave that if immunity is to fade, this is roughly around the time when it could be happening. We've also just passed the festival season where people were meeting each other. So there's a fear that if there is to be a third wave, then roundabout now is when it could be happening. Luckily, there doesn't seem to be too many signs of that on the ground, not in the numbers of the cases that are being reported, which are still at an all-time low, but all-time in the last few months anyway. Dr. Gupta, do you want to start it off? I just want to first ask all of you for your opinion on, could there be a third wave? Is there likely to be a third wave? What should people be watching out for?
Thanks, Vikram. I think that what I've learned from the pandemic to date is that it's humbling. And in part because of where we think we're turning the corner due to the heterogeneity of both the infection, the evolution of the virus, the number of people who've been vaccinated, and the durability of natural infection still sort of unclear. You're absolutely right. I think that we're not at a place where everybody has been vaccinated. Particularly, we know children, for example, in places like India have not been vaccinated. 27% are estimated to be fully vaccinated. And while the seroprevalence estimate from July of India shows that there was high transmission and high antibody prevalence, meaning that there were people who got infected, may or may not have known it, there's still a large proportion that are vulnerable, and the variants continue to emerge. So I think we have to continue to be COVID safe and not assume that we've turned the corner. We're learning that in India, I mean, in the US, it's still ongoing pandemic. And, we're seeing the separation of the vaccinated and the unvaccinated, where 11 times more of our hospitalization and deaths are among those who are unvaccinated. And it's popping up in new places where we see vaccine hesitancy the highest.
Right, Dr. Lakshminarayan, and I know last year when you said it could get really bad in a country like India, a lot of people said, don't worry, things are under control. And then the second wave came, which was awful. The second wave also ebbed away or went away faster than some people were fearing. What do you make of the sort of trajectory that this entire epidemic has been taking in India?
Thanks, Vikram, and thanks to Hopkins for organizing this. Anyone would create an app which is like, predict your own third wave could really make a lot of money here, because in a sense, the things that determine a third wave are all things that are known to us. We just don't know the probabilities. So it's really three things. One is variance. And we saw that with second wave. It was a new variant that was much more transmissible than what we'd seen before. Hard to have predicted, but we can always expect it will happen, particularly with COVID, because it is not just a zoonotic disease that comes from animals. We find that animals themselves are being infected. The lions with COVID in Singapore, snow leopards get COVID. So there's always a possibility of a new variant that comes back, and this should never be ruled out. So emergence of variance is the first thing that you should put into a calculator and say, how much do I think a new variant is going to come out of the woodwork and really affect us? The second is immunity, and immunity has three components. One is exposure, how much people have already been exposed. I think the seroprevalence surveys in urban India show, 90+% of people have already been exposed, which is not a surprise given how widespread, COVID really was. And but it doesn't mean that exposure has been that thorough in rural India as well. So exposure is one. Second is vaccination. We have to remember that most people in India are in the category of only yesterday, I think we have more people who actually have both doses compared to having one dose. But full vaccination coverage in the adult population is still under a third, compared to, 2/3 in many high-income countries. So we are still very exposed from a lack of vaccination. The third is, of course, the natural history of the virus, which is of waning immunity. So we don't really know a whole lot about this, and we don't know how quickly vaccine-derived immunity wanes compared to exposure-derived immunity. And this is still very much up in the air. So if we had answers to variants, these three things, and the last part is behavior, which is, of course, the big unknown. And behavior, of course, there's nothing to suggest that we are behaving any more COVID appropriately this November than we were last November in India. So it's a combination of these three sets of factors that if we had good answers to, we'll have a handle on when the third wave will be. But my suspicion is that we're not done with COVID yet.
All right, I'm going to actually take all of you through some of those points that you said, those variables. I mean, let's try and see where we actually stay on that. But first, if I can just get everyone else's broad sense, Dr. Shukla, your overall thoughts on third wave. Where do you think India is? How do you think India is coping right now? Dr. Shukla, I think he may have just suddenly dropped off.
Yeah.
Yeah.
Can you hear me now?
Yeah, we can hear you now. Yeah, sorry.
Yeah, that's right. So the positive rate has come down as low as 0.82% in India, and the daily cases as low as 10,000 being reported. Now there one can understand that this is the time, and we think that the efforts that have been put in, by the government, by the population, through the COVID-appropriate behavior, the vaccination, other precautionary measures taken, and the social distancing, different measures that were put in place, looks like that has really worked to some extent. But as rightly pointed out, we cannot be complacent, and we know that in spite of the fact that we have managed to get through these festivals in India without any sharp increase in the number of reported cases, there is no room for complacency. So I think that we have to wait till, as you rightly pointed out earlier, that both times in 2020 and 2021, it was started actually rising sharply from month of March, April, that period. Till that gets over, I think I will not be saying that we are safe, and we should continue appropriate behavior throughout the country, in each and every part of India. And I think everybody understands that, and we look forward to similar cooperation from each and every sector in the society.
Well, Mr. Rangaswamy, I mean, your sense on whatever you're picking up, and I know you're in touch with a lot of people here. When I look outside, when I see what's happening, I'm not sure I'm seeing a lot of COVID appropriate behavior now. It almost seems in many places people have forgotten that COVID ever happened. The people going to the markets, they're not necessarily always masked. Okay, some places they are, but by and large, I think everyone seems to feel that everyone's had it. It's over. It's something that's gone. Is that what you're picking up from your friends and family and all the people whom you're in touch with?
Yeah, I think our information at Indiaspora is anecdotal. When the second wave happened, we got calls from people for oxygen concentrators, for help. Indiaspora did a Chalo Give campaign here to send resources to India. And we got lots and lots of calls for people wanting hospital beds. They would call their relatives here and friends here to try and find a hospital bed in India, which was kind of a situation we had never seen before. And now compared to that, today, we're not getting those calls. I think a lot of people seem to have learned from the previous wave where, they lost relatives and friends to the pandemic. So from our diaspora point of view at this time, all we can say is there are not calls coming to us. There are no requests for help. And people seem to have learned a lesson, at least from the ones we talked to. So we're hopeful that that will be the case.
Okay, Dr. Lakshminarayan, let me just come back to those points, and I want to get everyone else's takes on that. Is it the case that right now there's not that much COVID out there in India? Almost certainly. It's not just because of the cases. ICU beds are empty, hospitals are empty. It's not that there are that many cases. What could account for this? Well, of the 4 points that you mentioned, it's clear that new variants have not really come, not so far, and let's hope that they don't come back. So that's one part of it. COVID appropriate behavior, I'm not certain about. Now let's come to how many people actually had it. What is the level of seroprevalence and how many people had it? There's a particular theory which I've kept on hearing, and I want you to get everyone's sense on that. One of the reasons why there are not that many cases out there in India is because in the second wave, perhaps there were a large number of undetected cases. And I've seen one study which says 27 undetected cases for every reported case, which is what would account for 80% or 90% seroprevalence. Everyone has been already exposed to COVID. So till that immunity fades, you're not really going to see a very major wave. Now, immunity could fade or you could have a new variant, but till that happens, maybe that's what's accounting for the low level of numbers. Is that a plausible scenario to your mind? And I'm going to throw this to everyone then. Dr. Lakshmanan, you want to go first?
Yeah, sure. That it's not just plausible, it's what all the data indicate. So the data come from two sorts of sources. One is where we have, of course, the seroprevalence studies, and then we know how many infections were reported. And our estimate after the first wave itself was that for every reported infection, there were another 25 to 30 unreported infections. And so you can do the same multiplier, and that's why the second wave was so important, because the level of lack of detection was even greater during the second wave, just because you remember what it was like. It was literally like a tsunami. Nobody could keep on top of it. The second sort of evidence comes from actual mortality numbers. Now, mortality numbers have been calculated by, Arvind Subramaniam and other people, all in various ways. In fact, we have a paper that's coming out just based on death certificate data in India. In places where we have good healthcare, we estimate that the excess mortality was about 5 to 6 times baseline mortality, which means if during that day, normally one person would have died in that town, 5 to 6 people died during that second wave. So I think the devastation that we went through in the second wave is beyond imagination. It's beyond imagination. Of course, those of us who lived in India at that time, experienced that firsthand, but I don't think we've even comprehended the numbers. So when people say, oh, we only have 500,000 deaths, no, not so. We probably had somewhere between 4 and 8 million deaths over the course of the pandemic. And that is now coming out from all sorts of different sources, not just one study. That's a pretty consistent picture, all of which indicates that India has been quite thoroughly exposed to COVID during the second wave. And we have gone through that fire. And that's why we're sitting a little more comfortably right now from not having widespread transmission. But waning immunity could change that picture.
Dr. Gupta, that's actually, I'm going to pick up on what was just said and to see whether you agree with that. India went through the fire in the second wave, perhaps a lot more cases, 25 times more cases than were actually reported, perhaps more deaths also than were actually reported. And that is the reason why there is protection right now. And that protection will continue until immunity fades. Is that a scenario that you think matches the data that you've seen so far?
Yeah, I mean, I do think that the data do support that. We certainly know, and India is not unique. Underreporting and under detection of both infection and mortality has been now described in many parts of the world. But when you have a surge that completely overwhelms pretty much every health system that's in place, and all the ability to not even be able to test people, to know how many people are admitted, how many people are dying, you have sort of makeshift crematoriums happening. All of that makes it even harder to know exactly the burden. And I think through work that Ramanan and many others have done, looking at different sources of data, do really point to the fact that the multiplier is probably at least 5-fold. And so that does really match a lot of what's been described. And so what I will say is that at least based on some of the scientific studies where we're looking at the durability of natural immunity versus vaccine-induced immunity, we know that vaccine-induced immunity, at least by measuring something that's difficult to do called neutralizing antibody titers. So it's not just testing the antibody when you do it in the blood, you have to actually do some very specialized assays to look at that. And so there are two types of immunity. There's something that's mediated by something called B cells, and we also have something called, that's the antibodies, and then two T cells, which is cellular, and that involves memory responses and other such things. And so what we're trying to do is understand, as we follow people longitudinally, to understand how robust is that response. And it matters not only in terms of the host, which is us. If we're immunocompromised, if we're older, if we have comorbidities, if we, things like cancer or diabetes, or we're really young, our immune system is not as robust. So that's another issue we have to take in mind. And even when we get vaccinated, not everybody has the equal response across all ages and across all morbidities. So what that all means is that over time, we're going to have waning immunity, and we think that certainly from natural infection, that happens more quickly than from vaccine response if you've been at least vaccinated with 2 doses of a fully protective vaccine. And we know there are differences in some of the vaccine candidates that are out there. So we have to put all of that into the equation, along with all the natural exposure that's happened.
So, Dr. Shukla, would you expect the immunity, if somebody's been exposed, to start fading, and if so, at what time? And the obvious counter to that is to vaccinate as many people as possible. One of the reasons I think India prioritized that first dose of vaccination so much was if somebody was already exposed and then they got the first shot of vaccine, it means you have got that double protection. But how do you see the vaccine program rolling itself out? Would you say start vaccinating people with the second dose faster and faster? Now, production seems to have picked up. So probably the right time for India to figure out what to do with the next phase of vaccination.
Absolutely right. And as pointed out by Ramnan, he said that yesterday we have now the number of people who have received 2 doses is larger than those who have single dose. That's about 380 million as compared to about 360 million who have only single dose. That is one thing, and that's why there's a very special campaign has been launched in India, Har Ghar Dastak. This is on 3rd November to 30th November to reach each and every household with the vaccines, so that we are able to actually not only do the first dose but also complete the second doses. So that is something very, very important. And for children also, now there is the government has already approved 2 vaccines, and we hope that very, very shortly that will also be rolled out. So of course that is very important. But going back to the question that you raised about the immunity, I was thinking that these the 2 other things that might trick this immunity, that population level, community level immunity that we are talking about, is one is a different variant of this virus, and the other, I have been thinking about something I have no answer, but let me just put it from my observation, is some environmental factors. Let me just tell you that when I was doing in the health ministry, there was an outbreak of H1N1, which is known as swine flu. It started in Pune and then spread to different parts of India. But what we observed when we were doing the surveillance and collecting information, that it is primarily the outbreak was in western part of India. So starting in Kerala, Karnataka, western Maharashtra, western Gujarat. And we found that the same thing happening this time also when during the outbreak of COVID-19, that these are the states where these were disproportionately affected as compared to states in the eastern part of India. And the only thing that I have in mind that there could be something in the environment, in the climate or environment, that might be causing it, but I have no answer. So I'm saying that could be another thing that might trick this immunity. Otherwise, I think the other points already made very valid points. But we think that vaccination is going to make a big difference, and India has already taken big step towards, as I said already, more than 100 crore vaccinations have been completed.
So, Dr. Gupta, if I could just ask you for the latest on medical science, and I'm sure a lot of people have that question. Where are we on the science behind how to treat this? So first of all, second dose, is that good enough? Do we need the boosters? Do we need to keep having boosters? We're hearing about these new medicines that can be taken. Pfizer, Merck, others have come up with it, which means you pop that tablet and you're not likely, your chances of dying or getting severe COVID get reduced a lot more. So is medical science now pretty much getting ahead of COVID to some extent, or no? Too early to say that.
Well, we've made a huge progress, clearly. I think that not only, so we've learned a lot about coronaviruses and immunity, and that's partly why we were able to rapidly develop the vaccine, but we're still learning. So there was a great study looking at, for example, the risk of infection after 2 doses of the Pfizer mRNA vaccine in the country of Israel. Israel had done a really great job of rolling out its vaccination. And what they started to see was that after a period of about 6 months, you started to have new infections increase among those vaccinated. And that really served as the basis for looking at what's the role for a booster immunization, i.e. a 3rd dose. And so it is clear that, as I was saying, that the durability of the immunity does wane over time, even with vaccinations as good as mRNA vaccines have been. That we do need to think about which populations require additional boosting. And the whole question is, do we actually need 3 vaccinations to complete the series of COVID? Remember, we're learning as we're going. And so the initial trials assumed that we needed a certain dose and 2-dose schedule, separated a certain amount of time, 3 to 4 weeks with the mRNA vaccine, with the COVID shield, longer interval. These things had to be decided very rapidly as we rolled them out. And so there's still questions about what is the dose interval, what is the benefit of the 3rd dose? Will some populations, including those who are transplant or cancer recipients, or studies to look at even a 4th dose, because even with 3 doses, some people don't get a full, robust response. And there are other diseases, hepatitis, measles, that need multiple doses to get full protective immunity. So what I will say is that we are learning at unprecedented speed. There are over 500,000 papers now published on COVID. And you can imagine the amount of data and information that's emerging is mind-boggling. I find it sort of challenging to keep up with the medical literature. And, I'm not reading 500,000, so I need digest. And I would go to reliable sources of information to get what's the latest. And of course, there is some controversy, and that's the fun of science, that not everybody agrees on everything. There are different ways to interpret data, but we do have a lot of good data. And so I think, we can get into the morality of doing booster shots in a high income country versus, waiting to distribute to others. But I will say we need both. And science is informing that we do need additional vaccination for at least a part of the population.
All right, I'm going to come to some of the lessons that we're learning for a lot of this. Dr. Lakshminarayan, let me turn to you now. You said everyone can predict their own trajectory. What would be the trajectory that you would be predicting, not just in India, but around the world? Is medical science going to be kicking this faster? Are people going to be vaccinated? Is it going to become endemic? What's your best theory on those? I'm sure you've read every single one of those 500,000 articles, so you know exactly what the data are saying. So tell us. You're on mute.
I've read all of those 500,000 papers.
Oh yeah, I'm so glad. So have I. Every single one of them. 3 times.
Yes. 4th to check. No, it's actually, what Amita is saying is right. We are, I think people expect science to have the right answers at all times. And I think they're watching how science actually unfolds in the course of this pandemic, which we're learning. We're learning every single day. And what is true, or what we may say today, will be out of date literally in a week. So everything that we say today will only be valid for a week. It's got an expiration date. Now, in terms of where we are, I think the short story is that we have vaccines, very effective ones, much better than we ever expected to have. But the distribution is highly unequal. There are at least 5 billion people on the planet who don't even have 1 dose of vaccine. So we're talking about India, which is in a very privileged position because of our manufacturing capacity. We have the developed world, which is in a different place. But large parts of the world just don't have any vaccines at all. So the chance for the virus to really come back in new mutations not only exists, but it's also pretty high. The fact that this is a zoonosis that goes back and forth between animals and us means that this will be a continuing threat. The fact that we have not got our global architecture. I'll tell you, the parts which are positive are, of course, that we now have potentially some treatments. But again, whether those drugs get out to the places that they need to, even though they are part of an agreement to manufacture in many countries, that's still challenging, because you have to remember, even cheap antibiotics don't get to every place in our country, even though we make the drugs and they're very cheap. So I think we have a very challenging period for the next few years, in fact, with respect to COVID. Remember that even an endemic disease is still a deadly disease. Tuberculosis is endemic in India. Malaria is endemic in Africa. but doesn't mean that these diseases don't kill, millions of people every year. At least TB does, and malaria hundreds of thousands of people. So an endemic disease is no cause for celebration. It just means that the disease is so well established in our population that we will just have no chance of really getting rid of it. And I think that it's still going to be a long battle ahead because of many of the challenges with this particular virus. It kills young people. There are not many infectious diseases that just go out there and kill 30 and 40-year-olds. It challenges health systems in ways with waves that we just have not seen for respiratory pathogens. This is not like the flu. So it's a clear and present danger. And I think we're in a lull right now, but we're going to see other forms of this virus going forward that we've not closed the book on COVID by a long shot. So all of the work that we need on oxygen, on making sure drugs available, on making sure that people are engaging in appropriate behavior. But I'll just make one last point. The change, I believe, Vikram, between last year and now is that with any new threat, people don't know how to calibrate their risk response. If you get on a flight, you know the chance that plane is going to crash and you can make your decisions accordingly. With COVID, people didn't know whether to touch a newspaper in the beginning, whatever, and they've sort of fluctuated between completely being, lackadaisical and being, super scared. Yesterday I was at a gym where the guy is like spraying sanitizer, not just on the machine, but like in the air all around the machine before getting on. I'm like, I don't know what he was hoping to kill with that sanitizer.
All those in this town hall who were microwaving their newspapers, raise your hands, or ironing them to make sure that there are no pathogens in them. There are a lot of people actually, someone just not touching them. So yeah, that was happening.
Yeah, but that's just a short story. I think we need to calibrate our behavior to be a lot more sensible with respect to the virus. Otherwise, we're going to be in big trouble as far as our economy and everything else also goes. Okay. We're going to have to live with it, but living with it means, what it really means is that calibrating to be sensible about risk. If you're going for a walk outside, don't need to wear a mask. But if you're going to be in a meeting room with 30 other people, maybe wear a mask, that sort of thing.
And if you're on a plane, certainly wear a mask. Mr. Rangasamy, let me just come to some of those lessons, because you and the Indian diaspora and a lot of people put in a lot of sterling efforts during the second wave in response to what was obviously an unprecedented crisis here in India. And I'm sure at that time, you and many others said, I wish A, B, C things had been done. And here are things that we must remember not to lose sight of. When the crisis fades, we must remember to do X, Y, Z things. What were some of those things that came to your mind at that time? And do you think those lessons have been learned? Oxygen plants, anything else that comes to your mind?
Yeah, I know Ramanan and his team did a lot of work around oxygen. So when we had to respond, we looked at things that were not related to oxygen. So we ended up at the diaspora and our Chalo Give program to focus on things that were not being dealt with, i.e. the migrant workers, if you remember, in India, went back once in the first wave, came back, went back home again in the second wave. So we focused on getting food to migrants. And that story is now gone away, but I think it still exists. A lot of people have problems with hunger that are not being addressed at this point. So we focused on feeding migrant workers through great organizations like Gunj, that many of you know, was our partner in that effort. The other thing we did also was an untold story in India is a lot of people had died and they were the sole breadwinner in the family. And there was absolutely no safety net for those people at all. So we worked with several small organizations whose horrible job was to actually go to crematoriums and cemeteries and others, find who these people were, find their families, and if they were the sole breadwinner who had passed away, to actually give them money. And in this case, we were fortunate enough to be able to give them digital money so we could track the response and not give out cash. But these are the kind of programs that we got involved with, because a lot of people started focusing on oxygen and healthcare, but we left out the daily problems of people. And that's what I'm afraid of as we move forward, is everybody's still focused on vaccinations, which they should. But what happens to people in India, because the diaspora is not going to respond as much if there's no crisis, right? Usually when there's an earthquake or famine or pandemic, we respond. But next year, say in 2022, there is no follow-on to the pandemic. How does India get money and resources to build the infrastructure for the migrants, for people without jobs. I think that's what I'm concerned with as we move forward.
Right. Dr. Shukla, other areas where infrastructure needed to be built, you think the lessons have been, we are hearing about oxygen, for example, plants being put inside. We are hearing that lots of possible new beds have been set up, which could be brought inside. Do you think enough has been done to take the lessons of the second wave? And if not, what still needs to be done?
Right, Vikram. As we were responding to the epidemic, lots of these facilities were augmented and upgraded. But at the same time, keeping in view the third wave, the government of India, they came up with a new preparedness project. And under this project, there are different components, and that is with the central hospitals, large hospitals, number of beds are being increased. At the same time, they are creating the beds closer to the community. So more and more facilities closer to the community. That is another area improvement. And this is about 23,000 crore project, which is being rolled out in the country. In addition to this, actually the e-Sanjeevani that was launched at that time, for teleconsultations, so that people could get advice remotely without having to go to a facility. That is also being now expanded under this project, and to do about 500,000 consultations on daily basis. In addition to that, they are also adding pediatric beds. About in every district now they are setting up one pediatric unit at the hospital level, as well as they are increasing ICU beds to the extent of 20,000 in the country, and 20% of these beds will be pediatric beds. In addition, there are other small things are being done, but these are add up to the building of the capacity on the side of the improving the detection, the surveillance, the response to the virus and other infections. The NCDC is also being strengthened. Genomic sequencing facilities are also being expanded in the country, as well as the EIS. That is the once we talk about what Dr. Raman was talking about, the surveillance and response to these outbreaks, it's very important that we also have different sets, the skill sets in epidemiology, entomology, virology, microbiology, and data analytics. And these are the areas which are being expanded under this entire project that has been launched by the Government of India, which is being implemented from July and likely to be completed on different components by March 2022. But one more thing I would like to add, that there are lots of lessons that we have learned, and a few just quickly I would like to give my thoughts on that. That this is the time that we should be actually concentrating now again on the primary healthcare system in the country. That we have to make it the central piece of the health system infrastructure in the country. We have to break down the silos. We have to use the digital routes. And I found that the 5 C's, which are very important in this entire system, the connecting, communicating, consulting, counseling, and caregiving through digital tools, it has been possible during this period. And we see through digital health mission that has been launched in India to see actually breaking new grounds and reaching new horizons in healthcare delivery and also health promotion and prevention.
All right, I'm going to start taking now questions, one by one as they're coming up. Dr. Gupta, one question that is showing up is about the entire question of variants, right? That some of the new variants haven't really gone past in India. Is there a risk of new variants coming? And is India doing enough on genetic surveillance and testing to detect the emergence of a new variant of concern? Is that something that you're seeing happening from whatever you're observing in India?
Yeah, so, any virus, and in particular coronaviruses, are rapidly, their job is to mutate over time, and some mutate faster than others. And certainly coronavirus from SARS-CoV-2 is no exception, and it has some what we call hypervariable regions of the virus. And that is what we sort of survey to look for evolution of variants. We are seeing, continued mutations, and what we end up trying to do is to determine what is their epidemiologic and their sort of clinical significance. One, you have variants that particularly in this spike protein of the virus, which can lead to increased transmissibility, potentially increased severity of infection, et cetera. And so I will say that I don't think any country, I mean, all countries are trying their best to put into place surveillance. Some are much better than others. It takes a certain amount of infrastructure to sequence the viruses. India does have a surveillance network that it's put into place, but it's still sort of only sequencing a small proportion of those variants, viruses rather, that are being identified. So, there is a system in place. It is doing the best that it can. It needs to be further strengthened. There's a global effort through what's called GISAID that's collecting all the viruses on all the different countries that are doing the sequencing and analyzing those data. It's looking for, emergence of new variants. And then, as I said, we need actually population studies and clinical studies to sort of say, okay, there is a new variant. What is its significance? Does it actually result in more transmission? Does it result in more hospitalization? And the only way we can do that is by having very robust integrated data systems that include public health, clinical, and virology laboratory monitoring that are synchronized. And so places like the UK, Israel, and some others have done a better job than others. And I will say in India, I'm hoping that over time, this is a big lesson learned. And as Dr. Shukla mentioned, we need to invest in primary healthcare. We need to invest in surveillance structures. We need to invest in science and in the talent pool. India is very lucky. We have fantastic engineers and scientists and a great medical education, but it is specialized. And you also have to have the systems in place. Data needs to be connected. It needs to be transparent. It needs to be shared, So I think there's room for improvement for sure.
Right, Dr. Lakshman, I just want to shift to the vaccination program now, which is up and running. Slow start, then it started accelerating, and now it's after China, by far the largest in the world. The phasing of this has been a subject of some interest because in the initial phases, vaccine hesitancy was not the problem and may not be the problem even now. The real question was how fast can India produce the 2 billion or 2.2 billion doses that are actually required to vaccinate the population. So production or the supply of vaccines was the real constraint. Are we now starting to reach the point where vaccine hesitancy may start to become a concern? Getting people to go back and start taking the shots, that becomes the gating issue for a simple reason that production is now picking up and picked up quite fast. Dr. Lakshman, I'm going to start with you, then I'll throw it to Dr. Gupta as well. Yeah.
It certainly seems to be the case. There was a news item a few days ago, which was of Bombay hospitals that had an excess of vaccines and were trying to unload their stock, even at a discount, and that's a bad sign. And also the fact that there are about 110 million people who have received the first dose but have not come back in time for the second dose. I wouldn't call it vaccine hesitancy as much as I would call it vaccine laziness. A lot of people were scared by the second wave into getting their vaccine, and since they see COVID sort of disappearing, it's just not, between life and going to work and your kids and everything else, getting this vaccine is just not a priority for many people right now because they don't see it as a major threat. The other part of this is also that even though it's very convenient to get the vaccine, it still is, adult vaccination is not a thing. I mean, in India, we don't go get seasonal influenza vaccines, which is something which, people in the US are quite used to. Every, winter, November, December, you go get a seasonal influenza vaccine. We don't have the habit of doing that here. And therefore, the idea of adults being vaccinated, I think we're treating it as if this is a one-shot thing without realizing that potentially this might be an annual event.
Right. So, Mr. Rangasamy, is it something, and I'm just about to play a video in just 2-3 minutes or sort of a campaign that can be done. Do you think this is something which the diaspora and private people and industry and others can help with, is to start spreading the message? Hey guys, don't forget, get the shot, go out, get vaccinated. This is one of the things that you need to be doing right now.
Absolutely. This is one of the things we've been involved with, is some campaigns, especially in rural areas, to kind of bring up the education about vaccines, taking vans and mopeds and buses and doing this education. This is something that foundations we're working with have actively started doing. Now, the second thing I want to highlight also is the migrant crisis. We don't want to forget that. I think a lot of these migrants need to find jobs in the places they used to live in and not come back to the cities, but because as we found out during COVID, it spread really quickly in the large cities. And these people had to go back and forth. So there's this whole question in the future, where do some of these people even live? And I think that's a discussion that India needs to have as we move forward as well.
Right. So Brian, let me drag you into the conversation right now. Brian, you'll recall we often had this conversation earlier, and I just play for everyone who's attending this town hall the sort of video, just a sample video, which is a sort of a message that perhaps it is now time to start putting out for people to tell them, go get vaccinated.
Absolutely. So with support from the Johns Hopkins India Institute and pro bono support from creative agency Wieden & Kennedy, we worked on a vaccination confidence campaign using some of the best evidence that we have around communicating around vaccination. And we're going to show one of the videos. If anybody has, if you're interested in seeing all of the videos, they're beautiful. We're really proud of them. You can go to tikalagvayana.org. We'll put it in the chat. These videos have been directed and produced by Bollywood director Neeraj Gaiwan, and they're just beautiful. We're really happy with how they've turned out. We're working with a number of partners on the ground to get these messages out to the communities where we know that vaccination would have the greatest impact from here on out. So we're going to go ahead and share one of the videos, but there are two others as well, and we're working on getting these out. And please feel free to share these with your friends, with your family, with everybody.
मी मंजुला हे काय इकडं कोलीवाड्यातच राहते सब मंजुताई बोलते हैं मेरे को कैसे है ना अभी काम पे नहीं जाएंगे तो घर का राशन पानी बच्चों के स्कूल का फीस किधर से आएगा और दिन भर थोड़ी ना मेरे झिंगे जैसे मर्द का मुंह देखते हुए घर पे बैठेगी मैं बरोबर है इतने क्या इसीलिए जब से टीका लगाना शुरू किया ना मैं ताबड़तोड़ जाके टीका लगवा के लेके आई जिद कर करके मेरे सारे घर वालों को भी टीका लगवाया औरत ना है मेरा देख के मेरी सारी बस्ती ने भी टीका लगाया मालूम है ए लक्ष्मी ताईला पण मीच घेऊन गेलते घाबरत होती अब सब मस्त है टीका लगाने का और काम पे चलने का हाय काय नाही का चल आपने टीका लगवाया ना हाँ हाँ
Yeah. So,
and we produce those with the Postgraduate Institute of Medical Education Research in Chandigarh as well. So those were our local partners, and we're just really thrilled with how they turned out.
Yeah, they're really great videos. There are many of them. You can see them, of course, on we're going to be starting to put them up on Heritage also, because the time is now right where supply is starting to pick up, and now we want to make sure that the demand also continues. I'm just going to take another couple of questions, and then I know there's some very special vignettes, Brian, that we want to go to, which I'll do that. A question around the lack of healthcare workforce. Is that a chronic issue? How can human resources be prepared, not just for emergency situations, but also for daily healthcare? And how is that process kept going? Dr. Shukla, why don't I toss that to you? Is the lack of workforce something that is a problem now in healthcare workforce in particular?
Right. Actually, during this pandemic, when this issue was very hot, and we know that in general, when we talk about lack of health workforce in the health sector, we mean doctors and nurses, but there are others as well. And actually, on the ground, you need the paramedics more than the medics. Actually, it comes to this kind of response all over the country. So what has been created actually is one database. Is the COVID Warriors portal. It was put in place as early as It was March, April 2020, and where we had put together the information about not only the medical doctors and nurses, for all the workers across the ministries, even community volunteers. So if you go to that portal and you can keep digging down, and you can come to the up to the district level to get the information about who are these, where are these people located, and then who are the nodal officers to be contacted so that you can use them. Secondly, we also use the online platforms to train them without there was no question of calling them to a central place for training and orientation. So that has been done. That is one piece of work that is still continuing, and it has really helped a lot in actually augmenting the workforce on the ground. Another thing that we did actually at that time was that we get people who are still not fully trained, like interns, like postgraduate, undergraduate medical students, and the BSc nursing, the GNMs, those training centers, and even the students, both PG students in biology, geology, biochemistry, psychology. We all actually we collected information and put them together in the same portal so that we could use them. Like for psychology students are very helpful for psychosocial counseling. That was very important. Mental health issues we are not talked about, but I think that has been one of the major challenges because of the pandemic, the kinds of problems people have faced at home when they were confined to their residence. So this is something that we are very, very effectively it has been put in place. But one more piece I would like to add is the involvement of the community. And this is what has sailed us through. The kind of response we have seen from the people, from the NGOs, from individuals, communities, actually in not only giving help to the people who are going to hospitals, but because they could not get food, nutrition, transport. Even we found volunteers when there were banks open in order to maintain social distancing. We had NCC, NSS volunteers actually doing that work. So entire community actually came forward, right, and we should capitalize on that and take it forward. So that's very important piece. One more important, just very small thing I want to mention about Kovit portal. Actually, Kovit portal is the tool. The way people have been vaccinated, such a large number, as I said, more than 100 crore in this country, and each and every vaccination has been tracked, and it is only through portal that you get the appointments, you get reminders, you get certificates. And this is the portal is so open that through API, it is able to shake hands with the third-party applications. So regardless of the fact it is in a public place, a private place, in any facility, they get information collected at the national level. And it is a very large database. And it is one of the things that we think we can take it forward to provide other healthcare services using this kind of database.
All right, Dr. Lakshmi Narayan, on one of the areas that you did a lot of work was around oxygen. I'm just curious, is that a solved problem in India? Now, we've heard of all these hospitals setting up oxygen plants. God forbid, if there is to be another wave, do you think we will at least not see those signs anymore of people going out, trying, scrambling for cylinders, scrambling for oxygen?
Vikram, there is oxygen which was visible lack of supply during the second wave. But we have to remember that at all times in India, there is an unseen demand. These are people, lots of people die, children with pneumonia, pregnant women, people with trauma, with injuries, who die because of lack of oxygen, because it is simply not available where they are. The PSA plants that have come in, as of date, I think yesterday the government mentioned about 1,200 PSA plants have been installed, and a lot of other assets that have come in through philanthropy and so forth have been deployed. It means that certainly the hit from oxygen during any potential future wave will be much less. But it sets us in a different direction, which is that we still have a responsibility, and this is what we are now working on, to build a national oxygen grid so that even during so-called peacetime, nobody dies because of lack of medical oxygen in India. And believe me, there's a lot of people who die because of lack of medical oxygen at normal times, because it's an essential commodity. It is just not available. It's not visible to those of us who live in the cities, who go into nice hospitals, who will never have to face an oxygen crisis. But if you try to find a cylinder of oxygen in any rural, sub-center or wherever, you're going to be out of luck. So we have a responsibility to fix that problem now. But from a COVID perspective, I think things will stabilize and will get better based on the investments that have been made so far.
All right. Now we have a couple of very special vignettes to show, which I'm going to toss across to Brian too. But Brian, hang on, just before we do that, I want to get final thoughts from Mr. Rangasamy and from Dr. Gupta, and then we can come across to you and perhaps play those two vignettes. Any final thoughts, Mr. Rangasamy, on this? Any way that you think the diaspora can help? Any message that you want to leave us all with as we wrap up?
Absolutely. Thanks, Vikram. I think the message is, how do we set up infrastructure for the future? How do we forget, like Ramanan said, the invisible people, especially those in rural areas? And how do we get them employment? How do we get the infrastructure built for primary healthcare? These are all open issues where I think there needs to be a lot more information and education, because it's not a crisis. People are not going to come forth from the diaspora and just make these investments unless there's a compelling case to do that. And we hope this kind of seminar is the beginning of starting to discuss what 2022 needs are and beyond, so that we can all be helpful in that case.
All right. Dr. Gupta, any final words or any words of advice that you might have for healthcare authorities in India or the government when it comes to next steps on vaccination, or whether they should give advance authorization as fast as possible for vaccination for children, or for the new medications that are coming, the Pfizer, the Merck tablets? What would be your words of advice to end on?
Yeah, so my words of advice is we need to invest for the long term. This is a massive shock to the system globally. We have disruptions in the economy, in education, in healthcare, modeling just even for a disease like TB, which was the global #1 killer, and India has 27% of the world's burden. The lockdowns itself have estimated that an increased 1.2 million cases over 5 years will be newly diagnosed, an increase of what we had previously. So with the education disruptions, the economic disruptions, the migrant challenges, we can't be thinking about this as just short-term, distribute vaccine and pills. There's just long-term ramifications. We need public health strengthening. We need investment in science and education. We need to sort of have much more confidence in messaging when there are public health messaging of how to be when we're confronted with diseases. So I will say that we need our diaspora, we need government and non-government sort of powerful partnerships. What we saw with the vaccine was 40+ years of investment in science, and then rapid public-private partnerships coming to bear to develop the vaccine. It's not like something that happened just in the midst of the crisis. So in the same vein, we need our public health system and our medical system and our education economic system be working ready to provide, pluripotent services that are not just focused on one disease.
All right. Well, Dr. Gupta, Mr. Rangasamy, Dr. Shukla, Dr. Lakshminarayan, thank you all so much for having joined with us. Brian, let me toss across to you. It's been really great hearing from all of them, but we have a couple of very special messages also in vignettes. So why don't I toss back to you, Brian, and perhaps you can introduce those.
And thank you, Vikram, for helping to moderate our wonderful discussion today. I think it was fantastic to hear from our esteemed panelists, and really looking forward to taking some of these conversations forward. We have Johns Hopkins has 2 faculty members who are either based in India or who have worked extensively in India and have deep roots in India. And we want to leave you all today with stories from them and their experience over the last 6 to 9 months or so. And so we're first going to hear from Dr. Vidya Mave, who's an associate professor of medicine at JHU and the School of Medicine. And then we will hear from Dr. Kunchok Dorji, who's an assistant professor also in the School of Medicine. So we'll leave you with these 2 vignettes, and just want to say once again, thank you for joining us this evening. It's been a wonderful discussion, and thank you.
As India was witnessing the devastating second wave of the pandemic, the demand for hospital beds, oxygen supplies, and ventilators soared. Maharashtra was one of the worst hit states in the second wave, and Pune became the state's pandemic hub with more than 10,000 cases diagnosed each day. The desperate demand for oxygen was nothing less than a nightmare, where the hospitals and the public health systems were struggling to accommodate the increasing number of patients and their relatives lined up outside the oxygen refilling centers. Many local and international bodies joined hands towards COVID-19 relief efforts in India, and the US was one of the major contributors. Hopkins India Institute responded swiftly to the situation and formed a COVID-19 task force. Many Johns Hopkins faculty, students, and staff have volunteered their time, talent, and raised funding to assist many existing and new India-based partnering institutions in their COVID-19 relief efforts. Some of these efforts in our region included the donation of oxygen concentrators to Pune platform for COVID-19 relief efforts, funding support to procure laboratory supplies and medicine to our partnering tertiary care government hospital in Pune, psychosocial counseling to pediatric and adult COVID-19 affected patients on post-COVID-19 care, as well as providing counseling to optimize vaccine uptake in the community. In addition, our group partnered with the Pune Knowledge Cluster, a Niti Aayog initiative on COVID-19 data analytics and supported genomic surveillance efforts. Our interaction with the local public health programs during the COVID-19 pandemic showed some stark contrast, ranging from care and treatment access challenges to extraordinary human compassion, dedication, and generosity. TB program, for instance, experienced compromised diagnostic and treatment services due to lockdowns and travel restrictions. The results of this may be far-fetching, where we are right now estimating a rise in TB incidence and mortality in the coming years due to increased transmission, and thereby having expanding lag in achieving TB elimination goals for decades to come. Similarly, maternal and child health programs suffered from a significant decline in childhood vaccinations compared to pre-COVID-19 period. Repercussions due to these challenges will have to be addressed systematically over the next few years, and I believe the public health programs in India are very resilient and can achieve these expectations. Despite these challenges, there are some promises that COVID-19 pandemic has taught us. For example, the accelerated development of COVID-19 therapeutics and vaccines within a few months provides lessons on rapid product and vaccine developments and pathways, which generally takes a decade or more. Human capital and infrastructure capacity developed for public health programs served a very great, unique purpose during the COVID-19 pandemic. For example, the TB program that had the capacity to detect TB using a special instruments called CBNAT, or a gene expert, utilized the same equipment to diagnose COVID-19. The HIV programs proactively mobilized the NGOs and ensured the continuity of medicines to the patients. The TB HIV staff also volunteered to do contact tracing and help manage COVID-19 patients, and more recently with COVID-19 vaccinations. The prompt actions of the national leadership, the sacrifice of the frontline health workers, including program personnel, greatly demonstrate the humility, integrity, compassion, and leadership exhibited at every level that helped India manage and face the challenges of the COVID-19 pandemic. With that note, I would like to thank you for listening and have a great day. Thank you.
Wonderful, and we'll show one more video from Dr. Kunjok Dorji.
At Hopkins, working with Dr. Richard Chason, my mentor, we started a Zero TB in Tibetan Kids program. So that program uses a comprehensive approach of TB education, screening, treatment, and preventive therapy, all under an umbrella of broad community mobilization. The goal of the project was to eliminate tuberculosis. And over the past, we have started the program since 2017, and over the past several years, we achieved remarkable success. Over 3 years, we were able to reduce the incidence of tuberculosis in the boarding schools by more than 80%. But then, unfortunately, over these past 2 years, as we all know, COVID-19 struck, and we had to stop all of our screening activities. So as we know, globally, decades of progress that has been made in TB has been reversed. the case notification in the TB, in the Tibetan community also got reduced by more than 50%. So we have been now tasked to work to overcome tuberculosis, to overcome COVID first, to be able to restart our work with TB. So since the pandemic started, end of 2019, beginning of 2020, we mobilized all our Zero TB Kids team on the ground to respond to COVID. So our nurses, our doctors have been at the forefront of screening people for COVID, providing care. And as you know, the Tibetan community in India, it's a very vulnerable population. Majority or a large proportion of the population lives in congregate living settings, in boarding schools, monasteries, and nunneries, where there is overcrowding, where there is a lot of interaction, transmission is easy. So if there is one case, for TB, for COVID, and the airborne disease, the transmission is a huge risk. So because of that, during the second wave in India, there were several outbreaks in the community. We have been investigating that. We have been trying to address the challenges, and we saw that in some of the monasteries, in the congregate living settings, the prevalence of COVID was more than 50%. But then there was one thing that we realized, because we have also from Johns Hopkins India Institute, we have been supporting the Tibetan community with vaccine. We know that this is a vulnerable community. If outbreaks happen, it could spread like wildfire. There have been significant toll on death and morbidity. So that's why we have started this drive for vaccine. But then we realized that in those congregate settings, in those monasteries where there were outbreaks, most of the people that got COVID, most of the people that died or got hospitalized, they were all people that were yet to be vaccinated.
So with that, I just want to say thank you once again to Vikram for helping moderate our discussion, as well as all of our esteemed panelists and to everybody who joined today for this fantastic discussion. Thank you again.
Thank you.
Thank you.
Thank you.
Okay. Gonna stop the recording.